Good afternoon, everyone. I want to welcome you and thank you for coming to Better Medicare Alliance's Congressional Hill briefing on improving consumer understanding of Medicare Advantage and their Medicare choices. My name is Peter Stein, and I'm Director of Government Affairs here at Better Medicare Alliance. I also do alliance development for BMA, as we like to call ourselves for short. As you may know, BMA is the country's leading coalition of more than 100 national, state, and local stakeholder organizations, all united behind support for Medicare Advantage, for the innovative, quality, coordinated, high-value care and enhanced benefit it delivers, as well as support for the more than 20 million Medicare beneficiaries, seniors, and persons with disabilities who actively choose Medicare Advantage as a source for their health coverage. BMA works to ensure Medicare Advantage's sustainability and stability through information, through research, through advocacy, and through the ongoing support of these very many ally organizations. We'd like to start things off right away, but before I do, I'd like to quickly introduce Better Medicare Alliance President and CEO, former Congresswoman Allyson Schwartz. As I think a lot of you know, Congresswoman Schwartz served here in the House of Representatives for 10 years from the Philadelphia and Philadelphia suburbs area. And she has really built her career as a thought leader and an activist on healthcare issues. She is known for her high level of energy and her ability to forge new ideas and bring people together to reach consensus on solutions to address some of the country's most pressing and challenging healthcare delivery problems. You have a full copy of her bio in your packets. So ladies and gentlemen, I'd like to turn things over and introduce Better Medicare Alliance President and CEO, Congresswoman Allyson Schwartz.
I was going to say, that was a very nice introduction. I would say, well, we paid him to do that, but we sort of did, actually. So anyway, no, that was great. Thank you, Peter, and welcome. See some people I might have seen when I was a member not so long ago, but I'm pleased to see you on a very sunny, yet still cool Friday afternoon in Washington. So we have hope for spring, I guess is the way to put it. But thank you very much for being here. Certainly it's good. I enjoy being back on the Hill and seeing some of my former colleagues and the important staff that helped us do all that we did. So thank you for being here. And I think we have some people from off the Hill, so appreciate that. Some of you may know, and I hope all of you do, that Better Medicare Alliance is an alliance of now over 100, we're actually about 110 ally organizations. We've grown quite a bit in our 3-year history. And I think it really represents the fact that stakeholders of all kinds, health plans, providers, health systems, aging service organizations, retiree organizations, business organizations, national professional organizations, all really believe that they do have a stake in Medicare Advantage and really are willing to support and say that they support the option of Medicare Advantage and the innovative work that happens, quality of care that happens under Medicare Advantage. So we're excited to represent all of them. It's sometimes a challenge to reach all that consensus that Peter talked about, but in fact there's a good bit of support here on the Hill and off the Hill, certainly from beneficiaries, 20 million of them, growing in number, but growing in percentage of Medicare as well. Because Medicare Advantage, as many of you know, really does offer a stable, accessible, high quality, cost-effective, and financially viable option for beneficiaries in Medicare Advantage. Those enhanced benefits are important to people. The affordability, the simplicity, all really matters. So we're here today because with 10,000 new seniors every day, becoming seniors, 10,000 people becoming seniors every day in this country, and that will continue for quite a number of years, almost doubling the number of people over 65 in the next decade. There are a lot of people, a lot of older adults with questions about what their Medicare options are and being able to find out and understand what they are. And then for us as policymakers, as advocates, to really make sure that beneficiaries have the information they need to make those choices, understanding that there is a basic choice to be made between fee-for-service and Medicare, and that in fact there are many choices once you actually, if you decide about Medicare Advantage. So we have some experts. Audra Davao is going to introduce both a report we did, but I really wanted to be sure that you understood that as part of what BMA does, which is really to to look at every piece of regulation on Medicare Advantage that comes out, to comment on it, to write comment letters back to CMS, to do some public advocacy. We are to talk with you about what we think we need, the kind of support we need from Congress to either change or to encourage those policies. We will be happy to talk to you. I hope you all sign up for our policy alerts so you can sound smarter and ready to go within hours, if not days, of any new regulation or other kinds of legislation that's introduced. So we really want to work with you because we feel very strongly that this model of care, a managed integrated system of care for beneficiaries, is really meeting the challenges of today and tomorrow's beneficiaries who are living, by and large, for years with serious chronic conditions they need to manage. And to have a team approach, to have a more integrated approach, to have a system that really supports you with a network of doctors really is proving to be extremely beneficial. And as you know, we're doing it at essentially, Medicare Advantage is doing it at essentially the same money as fee-for-service, with enhanced benefits, with say, some real enhancements in the kind of care you can get. So drive to value is something you hear about. It's what we work on. It's what we care about. And it's what we're all about. But again, to actually make sure that beneficiaries understand the differences between fee-for-service and Medicare Advantage from the get-go is really important. So thank you for being here today. We have some materials. You're one of the few who's going to get a really nice hard copy of the convening report that you can read through. So I hope you do. By all means, you can share it. It's online on our website, as well as a one-page summary of it. And look forward to working with you. Again, if you have questions for your constituents, for your district, I know in our packet also is an interactive congressional map, so you can go online and see what the penetration of Medicare Advantage is in your district, in your member's district, and the penetration of employer group waiver plans, those retiree plans, and even where special needs plans, which are dedicated to people with serious chronic conditions and are really interesting. So we want to provide that kind of information to you. If you're interested in something else that's not on that, you can always ask us. But it is a way for you to have at your ready some really good information. And again, dozens of fact sheets. My team that's written all those fact sheets would love you to look at some of them and read some of them. But if you have a question about how Medicare Advantage works, we should have the answer. And if we don't, we'll help you go find it. And so with that, again, thank you so much for being here. I want to thank the panel for being here as well, for taking your time to share with you your expertise in how we can do a better job. We, that is CMS, and primarily, but making sure that we really communicate with beneficiaries about Medicare Advantage as an option that they have. And with that, I think I'm going to turn that over to Audra Davao, who is our Director of Communications and has been leading this effort on, and she'll tell you why. I guess I'll mention, we actually have a lot of beneficiaries who talk to us. Not only do we have all those allies, but we have over 300,000 beneficiaries who interact with us, that number is growing, on what their experience is on Medicare Advantage. Our goal is to help educate them on Medicare Advantage and to help them become advocates for themselves. And they're eager to do that. So they sign petitions. They sometimes answer questions we have about their interaction. They tell us stories about how it's working. And then we have smaller groups that within that who come onto sort of, these are all virtual, but task forces that we did one on the Chronic Care Act. We've done one on the special needs plans, where they, again, can be even more specialized in the kind of advocacy they can do. And we, even on that map, we can tell you how many advocates that we have through the Medicare Alliance in your districts, or in your states, which is really great. So the reason for doing this is that they kept asking us some very basic questions about Medicare Advantage. And they kept saying, well, why don't more people know about this? Why can't they don't understand it? They want more information. And we started to look into the kind of materials that CMS puts out, both online and in hard copy, the interactions on the phone, Medicare.gov, all of that you'll hear about today, and really felt that it was just extremely important to bring their voice to the table in improving the kind of information that's available to beneficiaries who are really just, well, you'll hear more about this, but when they're faced with being on Medicare, they're first thrilled and then confused, So really, it's great to reach the age of Medicare and then realize that you're going to have health care coverage, and then you find out you have to pay Part B. You didn't realize that. And then once you get over that, you realize that there are choices to make and have a hard time sometimes figuring that out, sometimes for a year or two. So that's why we're doing this, and so we're glad to share that. So with that, I've taken more time than I should. Here's Audra Davao, who's going to actually lead you through our report and introduce the panel. Thank you.
Okay, good afternoon. I hope those sandwiches are crunchy and munchy. I'm actually hungry now just hearing you guys eat, but it's okay. Anyway, my name is Audra Davao with Better Medicare Alliance, Director of Communications. I was also a staffer here not too long ago. I won't tell you because I'll reveal my age. But really glad that you're here. Question though, how many of you have actually tried to help someone enroll in Medicare at all? Has anyone? Raise your hand. Really? Okay. Well, the ones who haven't, you're really lucky because it's very difficult. It's very confusing. You might get a headache. And so that's why we're here. We're here because it's really important. As you know, a significant portion of this country is enrolled in Medicare, and as the Congresswoman mentioned, it's 10,000 seniors every day. And if you don't know about Medicare Advantage Part C, increasingly many people are choosing and electing Part C. We're now at 20 million. That is a third of Medicare. And unfortunately, if you talk to a lot of seniors, you'll find that even those who are enrolled in Medicare Advantage don't know that it's Medicare Advantage. They may be familiar that it's their Humana plan or their Aetna plan, but are not familiar with Medicare Advantage, the program, and that's why we're here today. In December, we met with a bunch of thought leaders in the Beltway, about 50. We locked them in the room for about 4 to 5 hours. They still love us, it's okay. But we really wanted to get to the root of the issue, and it was thought leaders from across the board, those who are experts in communications, those who are experts on Medicare, patient groups, plans. It really ran the gamut, academics. And we really wanted to get to sort of what are the main questions when we're looking at why there's a lack of understanding with Medicare Advantage. So what we looked at particularly are the Medicare eligible population and their needs. You know, what are unique to their needs? Why is this population particularly struggling with this information? What are the readily available resources that they're using currently to evaluate their Medicare coverage choices, particularly Medicare Advantage? And then also, what are the barriers? What are the challenges? And ultimately, what are the solutions that we could recommend that are both easily achievable and those that might take some longer term planning? And that's why we have a lot of experts here today to share with you specifically in areas where there might be some solutions. But first, if you didn't believe me about lack of awareness on Medicare Advantage, we do have some statistics to share. 65% of those enrolled in traditional Medicare, that's original Medicare, Part A and B, are unfamiliar with Medicare Advantage. Then you'll see the second statistic. 43% Medicare eligible beneficiaries are unfamiliar with Medicare Advantage. So that means that when you put everybody together, those who are on traditional Medicare, Medigap, Medicare Advantage, still 43%, almost the majority, are still unfamiliar with Medicare Advantage. 44% couldn't tell you the difference between traditional Medicare and Medigap and Medicare Advantage. And 41% find confusion in trying to find the best Medicare Advantage plan for them. So if you're unfamiliar with Part C, it's a public-private partnership. It's private Medicare plans under Medicare. So that's 41% who say that they have difficulty finding the right plan for them. Okay. It's important to look at this now. We're 20 years into the Medicare Advantage program. It has evolved. It has changed tremendously since the start. And what we have there is just a graphic, and you can follow along actually if you pull out the convening report in your folders, it might actually help you. This graph is in there. What we have is the history and timeline of Medicare Advantage, so you understand sort of where we were and where we have come. And you'll see the changes that were introduced along the way in the Medicare Modernization Act, which named Medicare Advantage, and the Affordable Care Act. So major changes in what seniors are able to access under Medicare Advantage. And this is important for them to know as they're really trying to figure out what choices are available to them. They should know how the program has changed. Okay, so when we're talking about unique needs of the Medicare population, one of the major things that we have to look at, and if you're in healthcare, you know that there is low health literacy across the board in this country, right? They don't understand how to manage their healthcare. I don't understand how to manage my healthcare, so it's not unique. However, with the Medicare population, what we're really finding is that there's the extra barrier of health insurance literacy, lack of anyways, meaning that not an understanding of basic insurance concepts. And that's very necessary when we're talking about Medicare Advantage, right? Because it's private insurance. So being able to understand terms like cost sharing, deductibles, and what that means or as far as expectations for your healthcare needs is what we're talking about here. But learning style. So with older adults, there may be a bit of a digital divide there, right? We're coming along. Many of you know your grandparents and things are on Facebook. Maybe they're on Instagram now, hopefully. But still, there is sort of an issue there when we're talking about the types of materials and resources that are available to them. So really, what we're looking at is wanting to provide various forms of these resources. So it's not just online, or it's not just in a very thick handbook that they won't read, that really there are multiple access points for this information. And accessibility. So again, if you are from a different culture, if you have a language barrier, are you able to understand this very difficult information? And also the transition point. So when you're turning 65, how soon are you familiar with Medicare? How soon do you start to look at your choices? I can tell you that my father waited and, got overwhelmed and just sort of picked the default choice. But if there are efforts to engage with Medicare eligible beneficiaries before they turn 65, way ahead of time, perhaps then they will make a more active choice when it comes time. Okay, so at this convening, we looked at several studies about health insurance literacy in particular, and discussed basic tenets of them, and really what are the ways of which to improve upon health insurance literacy. So part of it is the presentation of materials. We're talking font, we're talking reading levels, we're talking about if it's presented in charts or bullets, things like that. But we're also talking about the basic level of language, so meaning how are we using regular language when we're talking about very difficult concepts? And also, how much can we expect people to consume information, understand information, and make active choices when we're talking about a large amount of information that they have to go through? I'm not sure if anyone has ever looked at the Medicare handbook, but it is, 100 pages, I believe. And Medicare Advantage, for the longest, didn't appear until page 65. So if you're trying to really figure out what choices are available to you, and we know that 24% of Medicare eligible beneficiaries look at the handbook as their resource, you won't even be able to get to Medicare Advantage until you really flip through a heck of a lot of pages. So that was an issue that we definitely addressed, and I know that Congresswoman mentioned that BMA has been in touch with CMS and really has been working with stakeholders to engage on these issues. The handbook in particular, we worked with CMS in the past year to improve upon that, and so now there's a very helpful chart on page 4 instead of page 65 that really explains the initial decision that Medicare beneficiaries have to make. So, existing materials. We just talked about the handbook. You will hear about the plan finder in detail from our panel. You will hear about SHIP counselors in detail from our panel and agents. But we are really looking to figure out which existing materials can we simply improve, and also, are there new tools that just need to be introduced? So really, are there new approaches to really engage with seniors in new ways? So we talked about improving upon the initial access point for seniors. That could be an employer. That could be a caregiver. There are no real formal ways right now of which CMS engages with caregivers and employers, and what we're hoping is that that becomes a reality in the future. Okay. Primarily, seniors receive information on Medicare from CMS, obviously, and also Social Security Administration. So a lot of folks don't realize that really when you're talking about Medicare Part A and B, you're engaging with Social Security Administration first. And what we're also looking to see is, what is the interaction between Social Security Administration and CMS? When does the handoff of information begin? So when a senior receives the initial letter from Social Security Administration saying, hey, you're about to turn 65, you might want to consider your retirement choices, and they get a response, or a senior enrolls, when does that information get to CMS, and when do they then hear about Medicare Part C? Because Social Security Administration does not typically educate on Part C. They're focused on Part A and Part B. Also, obviously, Medicare Advantage plans themselves do their own marketing and outreach. Counselors, agents, and brokers, which you'll hear about more when we talked about providers, caregivers, and employers. Okay. Well, I already talked about our handbook and our work on the handbook and the Medicare Plan Finder tool you will hear more about later. But we've also reviewed, as I mentioned, the Social Security Administration resources as well, because that is usually the introduction to Medicare for seniors. And so we want to look at sort of what are the resources available there, how much information is available on Medicare Advantage. Like I said, they don't focus on Medicare Advantage. I invite you to go to their website themselves and try to apply for Medicare and see what your experience is like. It's very difficult. It's not so easy to navigate. Okay. If you're involved with Medicare policy at all as part of your portfolio, then I'm sure you already know about the Medicare Advantage call letter that just happened a few weeks ago. There are important provisions in there that do touch upon this that are important for when we look at these issues in the future. One is, obviously, more flexibilities introduced in Medicare Advantage. Again, if we're looking at more Medicare Advantage plans, then obviously we really need to focus on the education and communication of Medicare Advantage even more so as more choices are being made available. Also, they've introduced more flexibilities and relaxed some of the regulations around Medicare Advantage plans' interactions with beneficiaries, including changing the definition of what's the difference between marketing and communications on education purposes. So we look at that as all positive movement towards improving understanding of Medicare Advantage. Our key recommendations, which you will find towards the end of this report, I don't want to go through all of them, but primarily the three that I do want to mention is that, of course, we're encouraging CMS and Social Security Administration to assess and update all of their current materials. But we're also hoping that there is a concerted outreach effort on Medicare Advantage on the part of CMS and any relevant stakeholders. And we're looking for more stakeholders to come to the table to really assess and provide their expertise on the landscape and what could be made possible. So I hope you will stay tuned with all the work that we're doing in this space. Afterwards, please sign up for our policy alerts. You will find the report also online if you want to share the electronic version of it. And now I will turn over to our speakers. First will be Dr. Brown, who will really explain her research on health insurance literacy, which is really the groundwork for a lot of this.
Okay, thank you. So as you were just told, my name is Dr. Virginia Brown, and I'm from the University of Maryland Extension, which is a department within College Park. For those who are not familiar with Extension, it is, rather than teaching on campus in the classroom, our classroom is out in the community. So you have a group of nutrition educators, community health educators, specialists in these different areas, youth development folks, serving the needs of the different communities that they work and live in. So what I'm here to talk to you today is about health insurance literacy education in general, and in particular about our Smart Choice and Smart Use health insurance literacy programs. So because I know this topic is extremely exciting for everyone, I'd like to start off with this visual. How many people have ever felt like this when shopping for health insurance? Everyone who's not raising their hand, I tend to doubt that a little bit. How many people have ever felt like that trying to figure out how to navigate their health insurance? And how many people wish you had help to do it better? Okay, all right. So let's begin here. We know from research that consumers are confused about and dread the purchase of health insurance. And in fact, very timely, research shows that people prefer to do their taxes each year than shop for health insurance. And this is across all the population, including those who have had health insurance previously and who have not had health insurance previously. Does not matter who you are. And we also know that a lot of this confusion comes around the simple terminology that health insurance plans use, like co-insurance, co-payment, deductible, out-of-pocket maximum, networks, PPOs, HMOs, all these O plans are very hard for people to just begin to wrap their head around. So in order to help people understand it, we need to target their knowledge and their literacy around this topic. So we know that health literacy is a way to build people's skills so they can better find, understand, evaluate, communicate, and use information to make informed decisions. That's the basis of all of health literacy. We want people to be able to access information that would improve their health and well-being, and then use it. And in order to do that, we know in order to improve any type of literacy, you need to be able to define the thing that you're targeting. And this is true for both consumers trying to use their plans and people trying to improve consumer understanding with research and education. So before 2011, there was not actually a health insurance literacy definition. There was not even a word for it. People talked about it, around it, but no one ever pinpointed what it was. And so in 2011, Consumers Union, the American Institutes for Research, and the University of Maryland Extension sat down and hosted a roundtable on health insurance literacy. And they invited health insurance professionals and researchers, financial literacy researchers, and health literacy researchers, consumers, government, and other folks to have an input on it, and created this working definition that we use today. So this definition, and we'll go into it a little bit more on the next slide, health insurance literacy is the degree to which individuals can find and evaluate information about health plans. From there, select the health plans that best fit his or her family's financial and health circumstances, so both of those come into play. And then once you have it, you need to be able to use it in order to fulfill your health and finance well-being needs. So at the end of this roundtable, we kind of divvied up the work. AIR said that they would take the lead in creating a health insurance literacy measure. Consumers Union was going to create unbiased consumer news around health insurance. And the University of Maryland Extension was going to work on creating a curriculum and education series, whatever it might be, we didn't know at that point in time, to help people better understand and use their health insurance. So let's look at health insurance literacy a little more. As I just said, it's both financial and health literacy. Those two pieces come together. We know that financial literacy leads to the wise purchase of health insurance based on your needs, and health literacy helps you understand and use it. But it's not just those two things. How many people in here know how to calculate their deductible and what goes against it? So not as many hands, okay. You're not alone. How many people know how to co-insurance and how to apply it towards your needs? Okay, so not as many folks. It is nice to see some hands, so that's good. So those things are numeracy. They all involve numbers. So health insurance literacy also requires a certain level of numeracy by the individual to be able to calculate how much they're going to be responsible for each month, and then be able to plan and budget wisely so that way they can meet their needs as they go through the year. And then it also requires document literacy. And if anyone's ever tried to read their evidence of coverage or explanation of benefits, you understand why understanding these documents are very important. So all of these go into health insurance literacy and are vital to help people understand. So when we sat down to do this, we knew that we looked at the research. There was not really a skill-based program, evidence-based, research-based out there currently existing. So we had to create this from scratch. And we knew that there was a lot riding on it. So we turned to, again, research and theory to help inform this. And we settled on these being the best ones to suit our needs to be able to create a health insurance literacy program. So we pulled from the theories of social cognitive and empowerment, evaluation theory, stages of change, and adult education. A lot of jargon, so I'll just tell you a little bit about how each one informed the program. With the social cognitive and empowerment theory, we use this to ensure that we are helping people increase their confidence, competence, knowledge, and skills. And this is through case studies, through practical examples, having them learn terms, and then adults actually work well when you have interaction. When it comes to evaluation, we had this through every part, from the very beginning of getting feedback on the curriculum that we were doing, through peer reviews with our colleagues and other experts in the fields, pilot testing it before it went live, certifying educators to actually teach it, and then tracking whether or not participants, experienced a confidence, a competence gain from start to finish. Stages of change is just a really useful theory. It tells you if this person's thinking about making a behavior change, how to move them from thinking about it to actually doing it. And it lays out some ways you can go about it. And then adult education theory tells us that when you're teaching to adults, you don't want more than 20 minutes worth of chunking of information, and that 20 minutes needs to be broken up. If you don't tell adults why they should care, you're going to lose them in the first 5 to 10 minutes. So you need to have content, participation or activities, whichever word you prefer, and then a review, or CPR as we put it. All of this and more went into the program. And so, as I said, we wanted to evaluate everything we did to make sure it was useful. And the data showed it worked. So we now have 2 curriculums, Smart Choice and Smart Use. I'll focus on one and then move to the other. So Smart Choice, we found in statistical significance that we were able to increase confidence and competence to make a decision. And a little bit about how we arrived at this. We trained educators in 7 different states: Delaware, Iowa, Maryland, Michigan, Minnesota, North Carolina, and Oregon. So all educators had to be certified and go through this process over a 2-day period. They were extension educators in each of these states, and they were either a financial educator, most of them a certified financial planner, a health educator of some sort, or a family resource management professional. So they did this during the enrollment period of 2013 and 14, and we actually reached closer to about 1,300 people, but we only had matched results for 994. From there, not surprisingly, we know that women tend to make the majority of health decisions in the home. So most people we talked to were women that came to the class. We had a good split on education level. About 25% had completed some level of post-high school education and on up. So fairly representative of what we see in a lot of the different states. Income was split, with most people hovering between $25,000 and $75,000 a year, and then some people at either end of the spectrum. And most people had already purchased health insurance at some point in their lives, but we did have people there who had never had it before because the ACA was now making it available to them. Regardless of age, race, education, income, and sex, everyone increased their knowledge and confidence from pre to post. And the same degree of change was seen independent of the group that they belong to. So that was nice to hear that the method to the madness proved itself in the end. And then we decided that this was not enough to help people choose. Now people need to use. And if you remember, I'm going to go back real quick. If you remember back, if it will let me, here, health insurance literacy has 3 parts. You need to be able to evaluate and enroll, which is A and B, but then you need to be able to use this thing once you have it. And so now we've been focusing on creating smart use programs around 3 different topic areas, helping people learn just basic steps that they can take to manage their health and wealth, benefits, what they are, how you might access them, who qualifies for what, how to find that information, and then understanding and estimating costs, which is a lot of numeracy in there to help people figure out how to calculate everything and make sure they're planning accordingly. So preliminary data, I have to say preliminary because we're still getting it in, but it is suggesting that this is also helping people increase their confidence and ability to use their insurance plans. And the greatest gains that we're seeing is around terms, because if you don't understand a thing, you can't even begin to use it or incorporate it into your life. How to estimate costs, which is very important when you sit down to look at a plan to understand how the premium and deductible, out-of-pocket maximums, co-pays, and all that should influence your choice. And then finally, around how to seek information related to coverage. And if anyone has ever had a question about your health insurance and who to ask, and then how to apply that to your situation, that's always an important need and skill for you to have. So I believe my time is up. I got it right, and I practiced to make sure I hit the 10-minute mark, so I'm very proud of myself. All right, so this is just my contact information, but thank you, and I'll have the next person come on up.
Just want to let you know that you all have index cards at your seats because we will be having time for questions and answer after the panel. And also, you will see a flyer in your folder about our conference coming up May 16th through 18th, of which Hill staffers get to attend for free.
Good afternoon, everyone. I know I'm like the post-cookie lull speaker, so I'll try to do something to wake you up. My name is Nora Super. I'm with the National Association of Area Agencies on Aging. How many of you all have heard of Area Agencies on Aging? Good, okay, or AAAs, we call them. My colleague, Amy Gottwals, is here in the front. She's our Chief of External Affairs and Public Policy. So if you don't know where your AAA, we have 622 of them across the country. They're in virtually every community there is. And so if you don't and aren't connected, we'd be happy to make that connection for you. And our mission is to build the capacity of our members so they can help older adults and people with disabilities live with dignity and choice in their homes and communities for as long as possible. Okay, there we go. So today, the Better Medicare Alliance has asked me to talk a little bit about SHIPs and how many people in their communities get information about health insurance, specifically Medicare coverage. How many of you all have heard of SHIPs? Okay, good. All right. Well, for those of you who don't know, the SHIP was created in the Omnibus Budget, or OBRA, in 1990, and it authorized CMS to make grants to states to establish and maintain health insurance advisory service programs for Medicare beneficiaries. These grant funds are made available to support information, counseling, and assistance activities related to Medicare, Medicaid, and other related health insurance options such as Medicare supplemental insurance, long-term care insurance, and managed care options. In 2014, under the SHIP was transferred from CMS to the Administration for Community Living, and this transfer really reflects the existing formal and informal collaborations between the SHIP programs and the networks that ACL serves. So about 2/3 of SHIPs are under the auspices of the state unit on aging in your state, and about another third are in the health insurance department of the state. But as we've been talking about today, Medicare is very complicated. So I've been working on Medicare policy, I'll age me and Joel, like 20-something years, getting to be close. It's really complicated. I have people that call on me all the time when they're enrolling in Medicare. And it used to be when I was young, and I was a young Hill staffer, I think, oh, these old people, they just don't understand it, you know? Well, it's really not because people are old and don't understand. It's because it's really complicated. My husband is actually turning 65 this year, and so many of his friends have been posting pictures of them getting their Medicare cards, as we were saying. They think this is exciting until they try to enroll, and so I think there's often this misperception that it's low-income folks or people with lower educations that don't understand Medicare. But it's really, I have a friend who's an engineer that I helped enroll in Medicare recently. And even with some of my husband's friends, one is a doctor. And he said, this is so complicated. Now, granted, he's a pediatrician, so he hasn't dealt with Medicare as much, but still, he's got an MD. So I think when you go through and see how many choices that you have and how to make the best choices, you'll see that most of us need help. This slide's a little hard to read, but you can find it also with one of our partner organizations, the National Coalition on Aging, that's done a lot of work advocating on behalf of SHIPs. What it says on top is today's Medicare beneficiaries choose from more than 20 prescription drug plans, an average of 19 Medicare Advantage plans, and Medigap supplemental insurance policies. So the Medicare SHIP programs help people navigate these increasingly complex choices with free, unbiased, state-specific guidance. And I really want to stress and say again, free and unbiased, which is something that we feel very strongly is really important for all Medicare beneficiaries to have access to. They help resolve enrollment questions, fraud and abuse issues, billing problems, appeals, and also enrollment in low-income health assistance programs. That bar, let's see, it's not even showing the whole thing, is it? There we go. The bar at the end shows you what they call most recently about. So it's like 4.6 million call about Medicare Part D. Whoops. And the next lower one there is Part A and B. That's almost 3 million. And then right under that is Medicare Advantage. It's 208,777, so a really close second. And the last bar is for low-income subsidy help or extra help with your prescription drugs. I also want to mention benefits enrollment centers. This is a relatively new program that's also run out of ACL. There are 69 benefit enrollment centers around the country, and of those, 22 are AAAs. And they focus on connecting Medicare beneficiaries with limited incomes to core benefits like Part D extra help, low-income subsidy, Medicare savings programs, Medicaid, SNAP program, supplemental nutrition assistance program, low-income home energy assistance program, for example. So often allow people to know for many of the benefits that are provided by Congress through law, that which ones they're eligible for. A lot of people don't even know these programs exist, and it can save them literally hundreds of dollars and really help them out. So when I was preparing for this, I wanted to make sure I could point you all to information if you want to find your SHIP, if you get calls from constituents who need help. And so I know you'll hear from Joel some about Medicare.gov and how it may be improved, which I really do agree with. But the best resource I actually found for finding your SHIP that had the fewest clicks was on Medicare.gov. So if you go in there and you put in your zip code or say where you're from, it'll come. It's only 2 clicks. I do also want to mention, though, that there is a SHIP Technical Assistance Resource Center, which I'll talk a little bit more about. That's more designed for counselors themselves, but that will allow you to find that information, but you can find it on their website. The Elder Care Locator, which is a national call center that M4A runs, also has information about your SHIPs, but people call for a variety of reasons. Health insurance is definitely one of the top reasons that people call, but not the major reason. And I think one of the reasons why they invited me to speak today is that AAAs are often the home of SHIP programs in the community. So 68% in our latest survey of AAAs are designated as SHIP programs. So again, we think this is important because AAAs are often a very trusted community resource, a place where people go for a lot of information and know that they can get unbiased help. Now, since we're up on the Hill, we wanted to just mention SHIP program funding and timeline here. As you may or may not know, the SHIP funding has been in jeopardy over the past few years. And, you know, as we've been talking about today, there are nearly 60 million people in Medicare now, or it was probably over 60 million, that's 2017 data, and 20 million in Medicare Advantage. And so I just have to say, it's kind of nuts that people would think they would take away money to help people navigate these really difficult decisions when the number of people around 10,000 a day are going into Medicare. So we think it's more of a budget issue, really, than not support for the SHIP program. But I just wanted to make sure folks were aware. It's the funding for SHIPs has been, you know, around $50 million for a while. But in fiscal year 2016, the Senate proposed a $22 million cut. In 2017, the Senate proposed eliminating SHIP. The President and Senate proposed to eliminate it. So we had a lot of advocacy efforts going on to you know, really called Save Our SHIPs because people were quite worried about this unbiased free resource not being available to Medicare beneficiaries and their families. Luckily, it was not eliminated, and in fact, the Senate boosted from the $47 million recommendation. The finally was boosted to $49 million, so we're still roughly at about $50 million on that, but just wanted to raise that because it's really critical that this program, which is funded under, you know, discretionary funds, continues to be funded. Some of the reasons why SHIPs are so important is they save a lot of money for people. You know, when people have an average of 20 plus prescription drug plans and 19 Medicare Advantage plans or supplemental insurance plans, it's often hard to know what's best for you, and the plans change each year. So your prescription drug may not be on the formulary anymore in the next year, and if that's a drug that you rely on and have to take, it's really important to know that information, to have someone walk you through that. The same with some of the rules in the plan that you may have been in last year may have changed, and so it may be structured Congress recently made some improvements in care for the chronically ill in 2020, so there'll be new benefits that come on board that you may want to take advantage of and need to know that it changes. So we always stress that people should look at all of their options every year. But the SHIP programs also report significant savings. So this just shows recent reportings in Massachusetts. There was $110 million in savings, $56 million in Michigan, $53 million in North Carolina, often either switching plans to one that's more affordable for them or saves on services that they use or benefits that they need specifically as individuals, or also just becoming aware that you're eligible for other programs that you didn't know about. And I just wanted an anecdote we had from our public policy briefing yesterday. We had a AAA director from Pennsylvania who one of their mantras this year and going up to Congress was "Ships save farms," and they said that just because they had talked about individuals who, because their health insurance costs were so high because of the co-payments on Medicare, and that you don't have a catastrophic limit on traditional Medicare, they were going to have to put their farm up for sale. But they sat down with a SHIP counselor and they talked, look, you really actually have this option, and if we do this, and we're able to save enough money where they didn't have to sell their farm. So it can really be a significant issue. As this report, documents, SHIPs oversee a network of more than 3,300 local SHIP offices and over 15,000 counselors. 57% of SHIP counselors are highly trained volunteers who donate almost 2 million hours of assistance annually. So again, the budget for this, as I mentioned, is about $50 million for the whole country. And we want to just stress that the volunteers in many of our programs are actually peer-to-peer counselors, which seniors really respond well to and feel like they can walk with them because they went through this process themselves. So there's a lot of evidence that suggests working with a volunteer or working with a counselor. So the last slides that I have, I'll just mention because they did a little. We weren't at the convening, and so I just wanted to add a little more information about SHIP trainings because there seemed to be some indication that SHIP counselors aren't trained well. But in fact, I got this data just from ACL yesterday about while they do have some flexibility, there are a lot of standards on what they have to be trained on at a minimum. And sorry, you can't see that slide, but maybe you can certainly talk to me after, and I can provide it to you, or Adjoa. I don't know if you all are going to provide the slides later. And this just provides a little more information about that. And finally, I just wanted to mention the Business Institute, which I'm the director of at M4A. We work with community-based organizations and health plans and hospital systems to connect community-based organizations in the system. And as Congresswoman Schwartz mentioned, as Medicare Advantage continues to grow, as many more enrollees are choosing it, we think it's really important that we continue to partner with the healthcare community within each local community so that people are getting the resources right there on the ground. So thank you very much.
Next, we'll have Erin Fisher. But now's a good time if questions are popping up in your mind to certainly grab a pen and write them down, and someone will come around and start to collect them.
All right, thank you, everybody. In keeping with the theme of confusion, I recently had a Harvard professor with 2 PhDs that couldn't figure out how to not only enroll in Medicare, but what plan he should take other than just Medicare A and B. So there is confusion. So I'm going to talk a little bit about the CE training that agents and brokers do, the certifications, what agents actually do, there's some matters of interest that we have, and then the word confusion surrounds HSA and COBRA, which there is a COBRA bill, which I'll go over in a second. So what agents do. So, did I skip one? Here's the training, yes. So agents go through extensive training every year to sell supplement, Medicare Advantage, and Part D plans. Not only do they have to have a health license in their state, and usually it's every 2 years that you have to get continuing education credits just to maintain that license, but to sell the Medicare Advantage and the Part D plans, you also have to take an AHIP course, which it can be up to 8 hours long, depending upon what your knowledge is in Medicare. And the exam is 50 questions. You can get 3 wrong. You have 3 chances. If you don't make it, then you don't sell Medicare Advantage or Part D plans. The carriers also have annual courses. They include some duplicates of the AHIP course, but they also have their own exams, which are also the same, 3 wrong, 3 chances. If you don't make it, you don't get to sell that carrier's plan. So agents spend a lot of time with their people that call them that want to go on Medicare. It's not only that maybe they need to go on Medicare, but do you need to go on Medicare? You might have a company plan. You might have children or a spouse that are under 65 under that plan. That all goes into whether you should even enroll in any part of Medicare. Also, there's a lot of confusion, which I'll go over in a minute, about HSA plans and COBRA, if you should go on Medicare with either of those type plans. We assist with them in how to enroll in Medicare. If you're 65, there's one method. If you're over 65, there's a different way that you need to enroll in Medicare. And a lot of these people don't know that. They also don't know the timing of Medicare, which can leave them out of the loop of having health insurance for up to 3 or 4 months if they don't know some of these federal regulations, which of course they just don't know because nobody tells them. Agents also offer ongoing support. It's not as though many of the ones that I know, we don't just enroll them and then that's it. Our service is free as well. We get paid by a carrier if a beneficiary enrolls through us. And we have ongoing support about what are they going to do next year? What questions do they have? If they're brand new on the plan, as you know, if you're brand new on anything, you have questions. So we want them to call us. We want them to get the right answer the first time. A lot of times when they call the carriers, they may or may not get the right answer, and of course they're on hold. So we're there to help them. We also have a program through the National Association of Health Underwriters that is the only Medicare certification program. So it's an extra level of learning. It's also about a 6 or 8 hours exam and course. The exam's not that long, the course is. And we also want our agents that are involved with us to take the course. It's another helpful way for them to say, I know a lot about Medicare, because it is really involved. So if you need an agent either in the ACA or on Medicare and you don't know where to go other than the SHIP people, you can certainly go to the NAHU website and find one in any state, any zip code, any locality in the country. So here are some of the things that are of major interest to agents. One is, what if an agent only sells one supplement plan? That may or may not be the cost-effective plan in your state. Most states have a minimum of 15 companies that offer supplement plans. They're actually offered by life insurance companies. They are not a health plan. So they are regulated by each state, actually. And usually, I don't want to defame anybody that does this, but usually a person that is selling only one supplement plan is really in there to get a person to buy an annuity, life insurance, long-term care, just any other products. So we have a lot of concern with that. We have a lot of concern with captive agents at Medicare Advantage plans. They're only selling one plan again. They're not giving the beneficiary the full scope of the plans that they can enroll in. Either is the person that sells only the one supplement plan. Some supplement people do not do Part D plans. they don't want to be involved. They have to get a license, take exams. So they don't want to do that, and they'll just say, I just don't do that. You can just go to Medicare.gov. Well, that's all well and good, but there's a lot of confusion on that website as well. In the beginning of the year, that website is not always correct. There are also a lot of intricacies with the Part D programs about pharmacies that people might not know about. So the parts of Medicare